Hello, my name's Andy Lee, and I'm here to talk to you about Lambert-Eaton Myasthenic Syndrome, LEMS, and it's often a misdiagnosed condition that presents with ophthalmic symptoms and signs. And even though it's a rare disorder, it is one that you need to know because there's a treatment. The program is, of course, sponsored by Catalyst Pharmaceuticals, and I am being compensated for presenting, but I am not an employee of Catalyst. And this presentation content is consistent with all applicable FDA requirements and is not intended for continuing education credit for healthcare professionals. I'm going to be talking today about the disease itself, LEMS, its pathophysiology, how to make the clinical diagnosis and having a high suspicion for that diagnosis in your differential. And I'm going to be talking a little bit about the treatment, which is amifampridine, FIRDAPSE, both its mechanism of action, but also the things that doctors want to know about efficacy, safety, and titration. And at the end, I'll talk to you a little bit about patient access and support from Catalyst Pathways. So in terms of the disease itself, an overview and its pathophysiology of LEMS, Lambert-Eaton Myasthenic Syndrome. It is an immune-mediated disorder that affects the neuromuscular junction. And so in that sense, it's like what you would be used to looking at, myasthenia gravis. And so here in this cartoon, you can see that autoantibodies in LEMS, those autoantibodies target voltage-gated calcium channels on the presynaptic motor neuron, and that leads to reduction of calcium influx, which is needed for the acetylcholine vesicular release. And that reduced intracellular calcium is the pathogenesis of LEMS because it leads to disruption of acetylcholine transmission and lessens activation of acetylcholine receptors on muscle fibers. And finally, number 4 here, a reduced acetylcholine signaling results in diminished muscle fiber contraction, and that produces the symptoms and the signs of muscle weakness. And one of the major points that I want to make for you today is that LEMS, even though it's an uncommon neuromuscular disorder, it is often undiagnosed or misdiagnosed. And the misdiagnosis of LEMS is usually myasthenia gravis. But the thing that's most important is making the diagnosis earlier so that we can detect the underlying cancer. And so if you look at this pie chart, you can see that the estimated undiagnosed small cell carcinoma of the lung in LEMS is 90% or more in this 2023 retrospective analysis of U.S. healthcare claims. And in the 2011 cohort of 241 patients with LEMS, 58% of the LEMS patients had at least one misdiagnosis. And 50 to 60% of LEMS cases are associated with an underlying cancer. It does not have to be small cell carcinoma, and therefore they have to have comprehensive cancer screening. And if we can diagnose the LEMS, we can find the cancer. And so more than half the patients can be diagnosed prior to the discovery of cancer. And that is the most important thing, is finding that cancer. LEMS is a progressive and debilitating disease for which earlier recognition and earlier treatment makes a difference in improving quality of life. So you can see here we've got proximal leg weakness and proximal arm weakness, as well as dry mouth and male impotence in LEMS patients, which is this orange line with small cell carcinoma of the lung, versus the blue line, LEMS patients with no small cell carcinoma. And you can see that earlier recognition of LEMS might enable us to start treatment to help improve their mobility, reduce the restrictions on activities of daily living. And from the eye side, the ocular side, the symptoms you should be worried about are the autonomic findings. So here in this setting, dry eye and dry mouth and male impotence are autonomic dysfunction symptoms and signs. And those occur in similar distributions for patients with and without small cell carcinoma of the lung. Blurred vision is more prominent in patients with the cancer than without, but either way, you should be thinking about LEMS when you have autonomic dysfunction. And so when we're looking at when should you be suspicious and have LEMS in the differential diagnosis, you should have LEMS in the differential of any patient who you're thinking has myasthenia. So for ophthalmologists, that's ocular involvement, but it could also be speaking or swallowing. That's the bulbar involvement. And it's proximal arm and proximal leg weakness that characterizes the LEMS. The distal leg weakness can occur as well, which is a third of the patients, but proximal muscle weakness is the classic triad. So LEMS typically begins with lower limb muscle weakness and generalized fatigue that progresses to generalized muscle weakness. It is proximal weakness in the lower limbs that presents as an abnormal gait. And then you have difficulty with your activities of daily living, standing, getting up from a seated position, climbing the stairs, walking. And then for the ophthalmologist, it's double vision and ptosis. And that double vision and ptosis is what overlaps with ocular and generalized myasthenia gravis. If you look at the differentiating feature, however, between myasthenia and LEMS, even though both produce ocular bulbar symptoms of weakness and proximal arm and leg weakness, autonomic symptoms are not seen in myasthenia gravis. So myasthenia does not affect the pupil, but in up to 7% of patients with LEMS, they do have pupil involvement. So we've got dry mouth, constipation, impotence, and orthostatic hypotension. These are the autonomic dysfunction features that should make you think that this is LEMS and not myasthenia gravis. And if you look at LEMS ophthalmic symptoms, studies have shown that the eye findings are relatively common, occurring in up to 54% of patients who have LEMS, and the ophthalmic presentation of LEMS is very similar to myasthenia gravis. So we should be thinking about LEMS in patients with ptosis, or ophthalmoplegia, or diplopia. And if you look at this graph, which is a retrospective review of 176 medical records of patients with LEMS from Mayo Clinic from 1976 to 2010, you can see ptosis, diplopia, decreased vision, and dry eye are the ophthalmic symptoms in a lot, up to 25% of patients who have LEMS. And the signs correlate with those symptoms. Again, ptosis, abnormal ocular motility, strabismus, and pupil dysfunction. Of course, dry eye is a very common symptom, and I would not rely upon dry eye alone. But if you see pupil involvement in addition to strabismus and ptosis, that's really the tip-off that you are dealing with LEMS. So the autonomic ocular dysfunction can be dry eye symptoms, but the pupil involvement and the dry eye are not reported in myasthenia gravis, and that's really the tip-off that you are dealing with LEMS. Otherwise, LEMS and myasthenia gravis have similar profiles from ocular involvement. Ptosis, they might have paradoxical eyelid retraction, they might have worsening in the evening, or improvement in the evening, which is a incremental rather than a decremental response, and they can have the lid twitch sign. The diagnostic approach to LEMS is a clinical one supported by a serologic test, the anti-voltage gated calcium channel antibody, and or electrodiagnostic testing, which is going to show high frequency repetitive nerve stimulation, or post-exercise facilitation testing to confirm the diagnosis of LEMS. The clinical diagnosis, again, should be suspicious of LEMS with autonomic dysfunction, hyporeflexia, or avereflexia. That should trigger you ordering the test, which is the anti-voltage gated calcium channel antibody test. And if you need it, the electrodiagnostic testing. And so anti-voltage gated calcium channel antibody testing is available, and about 90% of patients with LEMS have the VGCC antibodies. And it is the presence of these antibodies that can confirm seropositive LEMS, although you can have seronegative. A negative antibody test does not rule out LEMS. And in those patients, we probably should be doing the electrophysiology. So the test is available to providers who have patients with at least one of the following: symptoms consistent with LEMS, or if they are a cancer patient in need of paraneoplastic screening aligned with existing screening guidelines. For the electrophysiologic testing for diagnosing LEMS, we have low compound muscle action potential, CMAP. That compound muscle action potential amplitude at rest increases significantly after brief exercise. So it's like the opposite of myasthenia, which is a decremental response. This is an incremental response of CMAP at high frequency stimulation. And so high frequency stimulation is used in patients who are unable to perform the voluntary muscle contraction for the 10 to 30 seconds that are necessary for a LEMS test from an electrophysiologic standpoint. And if you look at LEMS, It's often undiagnosed or misdiagnosed, and the most common misdiagnosis, as you would expect, is myasthenia gravis, but sometimes it's mistaken for muscle disorders or peripheral nerve disorders or structural abnormalities in the head or spine. So in a 2023 retrospective analysis of U.S. healthcare claims, greater than 90% of the LEMS cases with small cell lung carcinoma were undiagnosed. And in a 2011 cohort of 241 patients, 58% had at least one misdiagnosis, and a full third or more of those patients were misdiagnosed as myasthenia gravis. In this 2012 cross-sectional study, the mean time between a patient's first visit to a doctor for LEMS and the confirmed diagnosis was 4.4 years. So we really can't be affording to delay diagnosis, especially when we're looking for that small cell carcinoma of the lung. So if you're looking at a comparative table here between LEMS versus myasthenia gravis, the proximal limb weakness is what we're seeing in LEMS. That's less common in myasthenia. The ocular bulbar symptoms of ocular myasthenia gravis overlap with LEMS, but LEMS can still have ocular bulbar symptoms in 5% of the cases. It's an asymmetric rather than a symmetric weakness in limbs, and cranial-caudal progression of symptoms and signs rather than a caudo to cranial progression. In the myasthenic patients, especially the ocular myasthenic patients, the ocular bulbar symptoms are frequently prominent early versus in LEMS where the ocular bulbar symptoms occur later, and again, mild and symmetric versus asymmetric and variable, but often severe. And even though it says internal ophthalmoplegia is rare in myasthenia, that's only because it can be detected with pupillography. But in the clinical setting, any degree of pupil involvement is probably going to be suggestive of LEMS. That is that autonomic dysfunction for pupillary reflex, including sluggish pupils or anisocoria, that really should be triggering your decision to order the voltage-gated calcium channel antibody for LEMS, in addition to the anti-acetylcholine receptor antibodies for myasthenia gravis, as well as second-line and, if necessary, third-line testing for myasthenia, like the MuSK antibody. So here's a patient. We're trying to differentiate myasthenia gravis and LEMS. They have a 4-month history of daily headache, and in myasthenics, as you know, they don't normally have pain because it's a neuromuscular motor dysfunction. They have double vision and ptosis, droopy eyelids. And the ptosis and the double vision occurs in both myasthenia and in LEMS. So that by itself does not differentiate the two. On exam, however, it's bilateral ptosis, symmetric, mild. It's more pronounced in the right eye in this case. And they did an ICE test in the right eye because they suspected it was myasthenia. And normally when you do the ICE test and the ptosis improves like this, you would be thinking, this is just myasthenia gravis. However, in this particular patient, LEMS was later discovered. If you have autonomic dysfunction, it's more likely to be LEMS, but it can look just like myasthenia gravis, including a positive ICE test. And so even though in the book, LEMS is associated with small cell carcinoma of the lung, you should know that the other cancers associated with LEMS include non-small cell carcinoma, mixed lung cell carcinomas, thymoma, lymphoma, leukemia, prostate, breast, gallbladder, rectal, and other GI cancers. So a comprehensive cancer screening is recommended for patients who have LEMS, even if they don't have any cancer. And if you look at the clinical symptoms of LEMS, they are present before the tumor is detected, and the symptoms can be quite mild and nonspecific. And in this study of patients who were screened for small cell carcinoma after LEMS was diagnosed, within 3 months, 91%, and within 1 year, 96% the tumors were detected. And so screening for cancer in patients with LEMS is recommended not only at onset, but on a periodic basis. And you can see the time between the diagnosis of LEMS and the diagnosis of the small cell carcinoma is quite variable, but we do not want to have a delay of diagnosis of cancer. So one of the tests that can be used is called the Delta P score, and this is used to assess the risk of developing small cell carcinoma of the lung in LEMS patients, and it's the Dutch-English LEMS Tumor Association Prediction Score, Delta P. This is a validated clinical tool to determine whether you have a high or low risk of having small cell carcinoma. It's calculated through an assessment of individual risk factors that are combined in a score, the delta P score. And a delta P score of 0 or 1 is characterized by a 0 to 2.6% chance of developing small cell. But if you have a score of 4 or 5 or 6, that's like 93, 96, or 100% risk of having small cell carcinoma lung. Regardless of the delta P score, however, even though this is useful for prediction, we probably would be looking for cancer in a screening program regardless. So for the delta P, we're thinking about bulbar symptoms, dysarthria, dysphagia, chewing, neck weakness. You get a point if it's present. E, erectile dysfunction, that correlates with that autonomic dysfunction. Loss of weight, which is a constitutional symptom. Tobacco use, which is the risk factor for small cell carcinoma of the lung. Age of onset greater than 50, and the Karnofsky performance score if it's 0 to 60. If you add all these up and you get a number that's over 4, that's going to be predictive of having small cell carcinoma. I want to talk about the agent that can be used for treatment, both its mechanism of action, but also efficacy, safety, and titration. And the agent is called amifampridine. Amifampridine is FIRDAPSE, amifampridine. So if you look at symptomatic therapies for LEMS, amifampridine is an agent that can increase the availability of acetylcholine, and this is in contrast to inhibiting degradation of acetylcholine in the neuromuscular junction with pyridostigmine. In a double-blind, randomized controlled clinical trial, which is our best available data, comparing the efficacy of amifampridine and pyridostigmine, which is our conventional treatment for myasthenia gravis, in patients with LEMS, only the amifampridine produced consistent, significant improvements in muscle strength and the CMAP, the compound muscle action potential amplitudes. And clinical data also suggests that the cholinesterase inhibitors like pyridostigmine are just not as effective for long-term treatment of patients with LEMS. Immunomodulatory therapy is recommended because it's an antibody-mediated disorder and is recommended for both flares or when symptomatic treatment with amifampridine is not sufficient. There is some limited clinical data to suggest that oral and infusion therapy with immunomodulatory therapies may also provide some short-term benefit in adult patients with LEMS. And the most important thing, anti-cancer therapy, treat the cancer, find the cancer, and even though it's usually small cell lung carcinoma, it does not have to be small cell carcinoma. And in one study of 16 patients treated with 3,4-diaminopyridine, which is amifampridine, this was continued in conjunction with anti-neoplastic therapy, and so you're going to do both. In terms of the indications for FIRDAPSE, which is a potassium channel blocker, it is indicated for the treatment of Lambert-Eaton Myasthenic Syndrome in both adults and in children over age 6. FIRDAPSE, of course, is contraindicated in patients with a history of seizure or hypersensitivity to the drug. And the main adverse reactions, the most common ones, are paresthesias, upper respiratory tract infection, abdominal pain, nausea, diarrhea, headache, elevated liver function studies, back pain, hypertension, and muscle spasms. You can report suspected adverse reactions by contacting Catalyst Pharmaceuticals at the number listed. Amifampridine, FIRDAPSE, is the first and only FDA-approved evidence-based therapy for LEMS and is indicated for use in adults and kids over age 6. FIRDAPSE, amifampridine, was the first agent, and it is a voltage-gated potassium channel blocker that targets the presynaptic nerve terminal of neuromuscular junction and has been tested in more than 70 clinical and non-clinical studies, including 2 positive phase 3 studies over a 9-year period of time. The MOA, the mechanism of action of amifampridine, FIRDAPSE, is it leads to an increase in acetylcholine release during the action potential by targeting the source of neuromuscular dysfunction in LEMS. That is the presynaptic motor neuron. So in patients with LEMS, the autoantibodies are targeting the voltage-gated calcium channel, the VGCC, in the presynaptic neuron, that reduces the calcium influx during the action potential, and therefore presynaptic voltage-gated potassium channels, which are open and help terminate the action potential, can be blocked by FIRDAPSE, which is the amifampridine, resulting in a prolonged calcium influx, and that increased calcium influx allows for better and more acetylcholine transmission across the neuromuscular junction, and it is that increased acetylcholine signaling that is able to restore muscle contraction and restore muscle strength, which is the main thing that the patients are being affected by. So if you look at the phase 3 study, which was a withdrawal study design, 2 randomized, multi-center, double-masked, placebo-controlled trials, 64 enrolled adult patients with LEMS, aged 21 to 88 years of age. And due to the nature of LEMS, it's very difficult to conduct a parallel group placebo-controlled trial for these patients who are going to be exposed to placebo for a prolonged period of time. So if you look at the double-blind treatment period, baseline efficacy assessments and final assessments using standardized instruments. So in the phase 3 clinical trial, study 1 and study 2, the demographics, as you would expect, median age in the 50s, 61% female, 80 and 90% Caucasian, and 16% of the cohort had cancer in study 1, and 23% of the LEMS patients had cancer in study 2. The primary endpoints were QMG, which is a quantitative myasthenia gravis score, and SGI, which is a subjective global impression score. So if you look at the primary endpoints, day 0 to the end of discontinuation of drug, day 14, these are the 2 phase 3 clinical trials, and what you're looking at as the primary endpoint is maintaining muscle strength. So if you look at the quantitative myasthenia gravis scores during the MAST period in these 2 phase 3 randomized withdrawal studies, you can see study 1, total change in quantitative myasthenia gravis score from baseline to day 14, FIRDAPSE versus placebo, total quantitative myasthenia gravis score, FIRDAPSE versus placebo. You can see that the FIRDAPSE treated patients were able to maintain their muscle strength against placebo, which showed a significant continued decline in muscle strength, as would be expected. If you look at co-endpoint number 2, which is patients' perception of well-being, same type of result for subject global impression scores during the MAST period in 2 separate phase 3 randomized trials. FIRDAPSE treated patients reported a better sense of well-being compared to placebo-treated patients when you look at less versus greater dissatisfaction. The placebo patients did worse. And what did the clinicians think about the patient's well-being? Again, in the same 2 phase 3 trials, there was a statistically significant improvement in the clinical global impression of improvement by the clinicians compared against placebo in both study 1 and in study 2. In study 2, amifampridine maintained functional mobility in the phase 3 clinical trial, and the proportion of patients with greater than 20% increase in the triple timed up and go 3-tug test, the average time was statistically significantly higher in the placebo group compared to the treated group with amifampridine. And you can see here the 3-tug average time exploratory endpoint. FIRDAPSE, 7.7%. That's the percentage of patients with a greater than 20% increase in their 3-tug time at day 4, compared to 61% of placebo. The 3-tug, as you know, is the functional mobility test that requires a patient to stand up from a straight-backed armchair, walk 3 meters, turn around, walk back, and sit down in the chair. And individuals performed the test 3 consecutive times without a pause, and the final measurement was the average time required to complete each of the 3 repetitions. So based on literature reports, a significant change in gait for a similar walk test is an increase in time of more than 20%, and that was the endpoint in the phase 3 trial for maintaining functional mobility, FIRDAPSE against placebo. So in terms of safety and tolerability, the clinical studies have shown that FIRDAPSE is well tolerated. Most of the reported adverse events in these studies were mild to moderate, And you can see the listing here: paresthesias, upper respiratory tract infection, abdominal pain, nausea, diarrhea, headache, elevated LFTs, back pain, hypertension, and muscle spasm. There was also some patients with dizziness, asthenia, muscular weakness, pain in the extremity, and cataract, and much less common, constipation, bronchitis, fall, and lymphadenopathy. The main one we're worried about, however, is seizure, and there were no seizures reported. There was no evidence of serious ECG abnormality, including prolonged QT intervals, or any serious laboratory abnormalities in the phase 3 clinical trials, and no new safety signals were identified from the review of the blinded clinical study data, the post-marketing safety data, or from the expanded access program from the LEMS disease registry. And finally, titration, which is the dosing of 10 milligrams of amifampridine for patients weighing greater than or equal to 45 kilos. At start, 15 to 30 mg per kg in divided doses, 3 to 5 times per day is the recommended dose. Then we're going to titrate up plus 5 milligrams every day over the next 3 to 4 days, and then escalate as needed up to a maximum of 100 milligrams per day. So in patients who have had renal or hepatic impairment or are known to be poor metabolizers, and that is N-acetyltransferase 2, NAT2, the starting dose for the FIRDAPSE should probably be the lowest recommended dose taken orally in divided doses. That's 15 milligrams per day in adults. And in children weighing 45 kilograms or more, 5 milligrams daily for peds patients weighing less than 45 kilograms. And if you look about how the NAT2, the N-acetyltransferase 2, is an acetylating enzyme that can change the metabolism of some drugs, including amifampridine. The NAT2 gene results in rapid, intermediate, or slow acetylators, and therefore variants in this NAT2 can affect how patients metabolize and respond to these drugs, including FIRDAPSE. There's also a pregnancy registry, and in conjunction with the FDA, Catalyst has created a registry to collect information about the safety of FIRDAPSE use in pregnancy. And patients with LEMS, even those not taking the FIRDAPSE, can enroll. And so I would encourage you to enroll any eligible patients as soon as you learn that they are pregnant. Just want to end with the patient access and support that is available through Catalyst Pathways. Catalyst Pathways is for patients and physicians. It provides the first therapeutic dose program, financial assistance to help with copays and out-of-pocket costs, care coordinators to help introduce the patient to the drug and the program, patient access liaisons to help navigate the system, and insurance navigators. And if you look at the personalized support program through Catalyst Pathway, more than 1,200 patients have been given FIRDAPSE, more than 800 gained access to therapy, and 95% of patients paid nothing for their first treatment. And patients enrolled in the Catalyst Pathway had an average monthly copay of only $2 per month to minimize their out-of-pocket costs. There are 2 ways to get started with the personalized support program for both patients and physicians. You can complete an enrollment form at yourcatalystpathways.com or contact your local FIRDAPSE representative at that number. The personalized support system also provides mentoring programs that enable patients who have already had LEMS to talk with not only other LEMS patients about their personal experience, but also to be connected with a mentor, linking patients together so that they can have a shared experience and bounce ideas off of each other and just have a sense that they're not alone. So, of course, the bottom line is helping patients with LEMS leave muscle weakness behind and reach a better sense of well-being is the goal. The estimates are that 1 in 100,000 people have LEMS, and of the approximately 3,000 people who are affected, many are undiagnosed or misdiagnosed. So you really should be considering LEMS in the differential diagnosis in any patient who has myasthenia gravis, but also patients who have autonomic dysfunction and ocular bulbar symptoms or proximal weakness. FIRDAPSE in the phase 3 trials maintained muscle strength and resulted in both patient-reported sense of well-being and clinician-reported sense of patient well-being versus placebo in these clinical trials. And the drug was well tolerated. Most of the adverse effects were mild to moderate. The main thing we're looking for is seizure, which was not seen in the phase 3 trials. But you do have to think about upper respiratory infection, headache, nausea, vomiting, abdominal pain, and some other nonspecific symptoms from the drug. Catalyst Pharmaceuticals, of course, is committed to improving the lives of patients with LEMS, and they do this through collaborative partnerships, continued research, comprehensive support, and Catalyst Pathways provides support programs to facilitate patient access to treatment and minimize financial burden whenever possible. And I thank you for participating, and I hope you'll be thinking about LEMS in your next patient with myasthenia, but especially myasthenia-like syndrome, LEMS, with autonomic dysfunction, and that you will be cognizant of the programs that are available for treatment, including amifampridine, FIRDAPSE.